My name is Mark Ruskin. I'm a pharmacist with Southern Illinois University Edwardsville School of Pharmacy, and I'm to talk with you today about medications and transitions of care. This is a very hot topic right now in the area of geriatrics, in particular with changes in CMS funding and hospitals receiving differential reimbursement based on readmissions to the hospital. My area of expertise is geriatrics, and there is a lot of literature out there discussing transitions of care in the older population, but very little literature focusing on palliative care specifically. So we're going to talk about general issues and how some of those issues may translate to the palliative care population. There's a couple of points I want to touch on today with you the next few minutes. One is to talk about transitions of care and high-risk medications and how these relate to the overall issue of transitions of care, and then also some strategies to try to reduce some of the negative outcomes related to high-risk medications during transitions of care. Like I said, my area of expertise is geriatrics, and we deal frequently with patients who use a high number of medications. And so I'm making an assumption that a lot of older patients are those same patients that are making up the palliative care population. Typically speaking, as the number of medications go up, the risk for adverse effects, the risk for readmissions to the hospital, the risk for adverse effects leading to emergency room visits all go up. And I think that's important to keep in mind as we look at types of medications as well as the numbers of medications that people are using. When we look at where problems can occur with medication use, it can be in a number of places. One can be within the healthcare system itself, issues such as medication errors, also with the patient characteristics, patients who have health literacy issues, patients who have problems adhering to medication regimens because of a complex regimen or, again, the number of medications they're taking. And then also with prescribers and clinicians making less than optimal choices about medication use, dosing, whether a medication interacts with one that the patient may already be taking. So there are a number of places where problems can occur, and it's important to think about all those before we start addressing preventative strategies for medication problems. In trying to define high-risk medications, there are a number of ways to look at it. One would be drugs with a narrow therapeutic index, and that has to do with medications that, if you look at the dose used to actually treat a disease and compare that to a dose that leads to toxic effects, there's not a lot of difference between those two doses. And so that's what defines a narrow therapeutic index drug, and can make it difficult to dose appropriately in patients who have multiple medications, multiple medical problems. Difficult to use medications. Most people are used to using pills and capsules, but when you start using liquid dosage forms or patches or inhalers or other devices that are not commonly seen, we can also get into problems there. Again, looking at drug-drug interactions, the more medications a person takes, the more likely they are to have medication-related problems. So these are some of the things to think about when, what are the high-risk medications. It's not always just what specific medicine a patient is taking, but also in the context of what else is going on with other medicines as well as other medical problems. I wanted to bring your attention briefly to the Beers criteria, and this is a list of medications that's been published, medications that are considered poor choices for older adults. And when you look through this list, there are about 140 medications that show up. The thing that's quite interesting is if you look at this list and find medications here that are suggested not to be used in an older population, there are quite a few medications that show up here that actually are used relatively frequently in the palliative care population, medications such as amitriptyline or diazepam or haloperidol or diphenhydramine. And that's not to say that in this palliative care population that's an inappropriate drug. I think it's important to keep in mind that the context of the patient or the patient population really is key to determining what the risks are. And so that would be an important thing to differentiate, a general internal medicine population from a palliative care population. When studies have been done to find what are the common offenders in terms of medicines leading to problems, in the general population, medicines that commonly come up include blood thinners like warfarin, insulins for patients with diabetes, antiplatelet medicines like aspirin, and even oral medications used to treat diabetes. And also, but a little less common, would include drugs like opioids, morphine, codeine, as well as sedative hypnotic drugs, drugs like lorazepam or Valium used for sedation. However, if you look at the literature in palliative care, there really is no data suggesting what are the high-risk medications. So we're really speculating where the problems might occur. But some of the drugs that would come up are not that different than medicines that we would see in a general medicine population. For example, opioids like morphine or Roxanol, liquid morphine, there are errors or problems that you could potentially identify or think about as common problems and ways to try to prevent these problems. For example, with liquid dosage forms, there's a great deal more risk for error with dosing because it requires the patient or the caregiver to measure out the actual dose. Also, it's relatively common for patients in this population to be changed from one opioid product to another, and that leads to potential problems with overdosing or underdosing. Fentanyl patches, because of the difference in that dosage form, it's administered by patch, and the patch is changed out every 3 days. It's important to keep in mind that when a new patch is applied, the old patch has to be taken off, and if it's not, there's significant risk for problems there. Even from the standpoint of prescription filling with opioids, for example, if a prescription is written for 1 to 2 tablets every 2 to 4 hours as needed, a supply may be given that in theory could last a week, but if the patient uses it more frequently depending on symptoms, it may be a supply only lasting 3 or 5 days, and then the supply is exhausted before there's an opportunity to interact again with the healthcare provider. So some of those things might come up relatively commonly in this particular population. Also, benzodiazepines given in liquid dosage forms or in sublingual dosage forms can potentially be problematic and risk for adverse effects. Over-the-counter antihistamines have the potential, like Benadryl or diphenhydramine, have the potential to increase the sedative effects of benzodiazepines or some of the other opioids that are being used at the same time. Insulin, again, one that would come up in a general population, is something that might come up in a palliative care population too, as patients, maybe their diabetes is progressing, they're not eating as much, they're losing weight, but the same insulin dose may lead to a higher risk of hypoglycemia and problems in that area. So some of the medicines may actually overlap between the two populations despite lack of data in the palliative care population. Some of the interventions that have been tried in the general population, med reconciliation, whatever setting you're talking about, whether it's home, nursing home, or in the hospital, med reconciliation is very important. We have to know what medications patients are taking and how they're taking them, because a bad list or a list that's inaccurate is only going to lead to problems. So med reconciliation, no matter what the setting is very important to trying to prevent some of these issues. There are a number of pharmacist interventions that have been tried both in the hospital setting and the community setting. Having pharmacists involved in palliative care, I think, has been shown to be beneficial from a number of perspectives. Intervention packages, this really has to do with the inpatient setting and multidisciplinary or interdisciplinary interventions to try to reduce those readmissions to the hospital within 30 days. So there's not data to suggest that these intervention packages are beneficial for palliative care patients, but I would suggest that a lot of the principles behind these approaches are important for this population as well. Community and pharmacist involvement, I think, has the potential to do a lot of good in palliative care, in general population, whatever we may be talking about. Community pharmacists have a lot of access to patients. What they tend to not have is access to information about patients, and I think there's a lot of interest in how can we involve community pharmacists in this type of a setting, a transition of care, to be one more participant to try to prevent some of these problems as they move from one setting to another. I think you're seeing a resurgence of independent community pharmacies to try to fill some of these roles related to transitions of care and increasing coordination of care. So I think that's something that we may see increase over time. So with this slide, I'd like to thank you for the time, but I just want to keep in mind that this slide just lists several principles that I think are important relative to transitions of care. In this particular context, it's talking about from the hospital to the community, but I think it's true no matter which setting you're talking about. Not only medications, but follow-up care and coordination of care, discharge planning, advanced directives, advanced care planning. All these factors are important when it comes to high-quality transitions in care. Thank you.